Everyone. It's really hard to make this presentation because there's a lot of enthusiasm about azithromycin, like all articles you were looking at. Really hard to find one, but I hate to be the villain, but since this is a con, I'm gonna go after Yasser. Alright, so I think he already talked about COPD exacerbation, the effect as far as quality of life, mortality. What I really want to emphasize is that in terms of the mortality impact, it's mostly done for patients that were hospitalized, either who are in the ICU or on the ventilator, or with hypercapnic respiratory failure. Do admit that there is a significant economic impact. There is significant effect on the quality of life as far as and the acceleration of their lung function decline. However, the question is really azithromycin the answer for that? Again, we all know that prevention of COPD requires multiple things to be done: smoking cessation, vaccination, medical treatment, knowledge of current therapies, including inhaler, and adherence to treatment. So there's really a lot of things going on. Again, since I knew Yasser is going to talk about this article, I also use this article to kind of make argument against, at least not to this level. So this is, again, as Yasser described, it's really well done, randomized clinical trial. All the patients have the same baseline characteristic to start with. The exclusion criteria, again, what's more would be is, again, this heart rate and prolonged QTC patients being excluded, and also patient taking QTC prolongation medication that can prolong QTC being excluded is a big factor, because as we talk more in the further, we'll see that most of our patients will end up having one or the other, and we're excluding them. They did look at the first time to first exacerbation, and they also looked at quality of life, colonization with bacteria, and adherence to the study. And this is their finding, basically. Patients who are taking azithromycin have not as early as the placebo group as far as first time to COPD exacerbation is about 3 months difference. They did report improved quality of life. However, they didn't really meet the criteria they set up for quality of life, but most patients in the azithromycin group did report improvement. They did have significant higher nasopharyngeal colonization of bacteria that are resistant to macrolide. And this bacteria specifically, strep, staph, Haemophilus, and Moraxella, which are the common causes of community-acquired pneumonia or sinusitis. The concern again remains is that we really don't know the profile of azithromycin when taken for longer than a year. However, we still don't know. Most of the studies that has been done on azithromycin and its effect are on patients that are taking it for 5 days or a little more than that for infectious reasons. So we still don't know that. And most of the studies seems to exclude patients that they think are high risk for cardiac complication. And we still don't have a lot of information about bacterial resistance. And then, something that concerning is that most of the patients that we think may benefit from azithromycin therapy are excluded from the studies. This is what the conclusion I had to quote this from the article. It says, given the deleterious effect of acute exacerbation COPD with respect to the risk of death, quality of life, loss of lung, cost of care, adding azithromycin to the treatment regimen, patients who have had acute exacerbation COPD with the previous year or who require supplemental oxygen is valuable option. I make the argument that when you look at the secondary outcome on this patient, and really most of the patient that they really is saying they prevented is just unscheduled office visit. There is no, when you look at the hospitalization related to any cause or hospitalization related to COPD exacerbation or any urgent care visit, there is no difference. And then when you look at the absolute numbers, there is still about 1,200 patients in the azithromycin group and 1,300 patients in the placebo group that still had unscheduled visits. So you have an add of 143 patients that are just different, and so we're justifying based on 143 patients to make it apply. And then again, is the cost, can we justify the cost from that number? This is the other study Yasser presented. Again, this is a patient with cardiac failure and prolonged QTC. Cardiac arrhythmia were excluded, and I'll talk more about the prevalence of cardiac disease in COPD patients. So really, obviously, we're selecting patient that we would think is going to give us the result we want. That's fine, but I think when we apply it, we have to apply it also to those specific patients. And also in this article, they described moderate exacerbation was defined as a sustained worsening of symptoms for at least 2 days that required treatment with oral corticosteroid. In the ATS definition, we'll talk more about mild to moderate. Again, the definition kind of varies, and they kind of clustered moderate and severe exacerbation together. So really, the ATS definition is different for exacerbation of COPD. So it's kind of pulling in less symptomatic or less severe patient towards there. And then when you look at the absolute number, in terms of hospitalization for COPD exacerbation, it is statistically significant, but it's not, and then their sample size is not that much to really give it that much power. I guess the question I'll want to raise is that are all COPD exacerbation the same? Again, this is a ATS definition and the European Respiratory Society definition of COPD, like mild to moderate being those you treat them at home, and severe requiring hospitalization, and very severe that leads to respiratory failure. Obviously, we know that patients that are admitted to ICU have worse outcome and increased mortality. So if azithromycin does in fact prevent that, then you say maybe worthwhile. So I guess the argument is that, again, is prevention of mild COPD exacerbation worse the adverse effect related to azithromycin use? So what are the adverse effects of azithromycin use? Before I go in there, I just want to mention this. I already said it before, but COPD is now being recognized as an independent risk factor for cardiovascular disease, and patients with COPD are 1.5 to 5 times more likely to have coronary artery disease. There are even reports of accelerated atherosclerosis in patients with COPD. Of course, macrolides prolong QT in 2 different ways. One is it directly affect the cardiac muscle, and the second is it affect metabolism of arrhythmogenic drugs. Of course, QT prolongation is a surrogate marker for ventricular arrhythmia, and particularly torsades. This report from the FDA that looks at adverse outcome, there were 63 cases of azithromycin-related ventricular arrhythmia, with 59% of them in patients that were taking concurrent QT prolonging drugs. The risk is less in general when you look at it, but when you look at patients with cardiac disease, it's much higher, which means our patients with COPD are at high risk. This is a cohort study from Tennessee medicated patient that looked at cardiovascular and all-cause mortality due to azithromycin, and they compared them with patient who was not taking antibiotic, patient taking amoxicillin, and also ciprofloxacin and lidocaine. And they looked at it. They found that 59% of days were associated with azithromycin. They're really concentrated in the 10% of patients that are thought to be at high cardiac risk. It is a retrospective study. It's an observational study, so there is a lot of limitation. We don't know about the comorbidity of this patient, what medication they were taking. However, when you look at the temporal association between the time of azithromycin administration and the onset of this cardiac death, you may it might be plausible to at least give it a consideration. Again, this is just a graph of that from that study. Ototoxicity is common, also reported in patients. It seems to be reversible when the medication was stopped. And that New England Journal of Medicine article, there was 25% compared to 20%. And at least in 1/3 of those patients, actually, the hearing went away while they're on therapy. However, again, when it's taken for a longer time, we don't know the outcome from that. And then most importantly, the public health effect of microbial resistance. We use azithromycin for treatment of community-acquired pneumonia. We use them to treatment of some of the mycobacterium. At least from our that New England Journal of Medicine publication, there is 81% incidence of resistance to common bugs as opposed to 41% in the placebo. So the question is, again, is yes, this is a good study, and yes, this is a really well randomized study, but again, did we really do everything we can for this patient before we consider adding more medication? Again, really, I would like, because always when we see patients in clinic, and the first thing we ask is, are you taking your medication the way it's prescribed? So really, is patient adherence to the treatment, and is there anything we can do about adherence to prevent frequent exacerbation? Again, adherence is supposed to maintain the patient health status, decrease health cost. If it's done appropriately, it's supposed to reduce exacerbation, hospitalization. Now, the World Health Organization reports in patients who are on a long-term therapy in chronic disease, the adherence rate is 50%, and in COPDs, the rate is about the same. And despite the gold criteria or gold suggestion, adherence still remain poor. Again, we can just briefly talk about primary non-adherence. Is just basically patient from the get-go not doing what they need to do, not filling their prescription, or not following any exercise programs. And then secondary non-adherence are a lot of things, including improper use of medication, alteration of dose, not following up, and not continuing with pulmonary rehab. But really, what I would like to stress is that adherence is a multifactorial thing. It's not just the patient not doing their job. I think it has a society factor and a treatment factor. As far as the patient is concerned, I think patient's belief makes a big difference. There's a lot of times when we say, patient, do you have COPD? And they tell you, that's what I was told. So from there is a problem of believing they have that. Society-wise, I think patient-physician relationship, there is a study that showed an action plan for COPD patient. It didn't really show decrease in frequency of exacerbation, but it did decrease the duration of exacerbation. And then, of course, the method of administration, I think the dosing regimen, and I really want to focus on polypharmacy, because most of our patients have a lot of comorbidities. They're taking multiple medication, and we're adding more medication that they may or may not be compliant. I just had to put this one because it's really interesting, because they looked at non-adherence to prescribed medication, and I was expecting that patient would be more compliant with sympathomimetic medication, because that's what we tell them to use for rescue inhaler. But this explains why patients use things that they believe can give them a quick relief. And again, when you look at the situation where patients require steroid and antibiotic, that's usually in the setting of acute exacerbation, which they believe is going to help them breathe better, feel better. So they tend to have high adherence to those medications as opposed to the long-acting anticholinergic, which they barely use. I just want to stress that gender, age, level of education, and socioeconomic status has no influence on adherence. So with adherence, the challenge is we don't have a gold standard, and most of the studies, there is a literature review of 7 interventional studies that raised, again, we need more research in this because it's very hard to delineate. But really, going back to the point, is what is unknown? Again, we don't know which patients benefit the most from azithromycin therapy. We don't know what the optimal dose that maximizes the effect and minimize the risk, and then we don't know the duration of therapy. They did it for a year. Our patient has COPD for the rest of their life. Again, balance, I guess. So there is some evidence showing azithromycin benefit, but really it doesn't come without any penalty. I think we should really look into patient's risk, individualize the treatment based on that. We should also consider the risk that comes with macrolide resistance. I think we really have to find, may not be able to do it, but at least get close to finding patients that are most likely to benefit and less likely to harm. And then, of course, if we can do more studies on intervention that improve adherence. I guess now we can open the floor.
What about the rebuttal?
Yeah,
Yes, I think Go ahead.
Yeah,
So
go ahead.
basically, azithromycin is the same as any other medication. All medications, they have side effects and advantages. So we need to balance between both the